for College Scientists. It's a national organization that supports outstanding students in STEM fields. The Honolulu chapter was founded in 1974, and we've been able to award more than $2 million to nearly 600 students in that time. John A. Burns School of Medicine is one of the 7 research-oriented units that we support at the University of Hawaii. We want to thank the school for hosting this Zoom event and being our partner in promoting usually young, sometimes not so young, scholars who stand to make a difference in science, technology, and health fields in the United States.
Well, I'm delighted to introduce Margo, who had a distinguished academic career at Brown, and then the typical progression through med school and medical residency and cardiology fellowship. She spent a lot of time during her training taking care of poor people, both in this country and in Latin America, and came here exactly 10 years ago to join the Queen's Heart Group as a general cardiologist, but also with special skills in nuclear cardiology and echocardiography, which she continues to exercise to the benefit of our population here. She is also a certified yoga instructor and accomplished violist, and I think that that may be just as important as any of the cardiology skills. She has a special interest in heart disease in women, and is going to discuss that with us too.
I am just honored and humbled to speak to you guys, because I know you have a great body of knowledge and experience. So hopefully this will be fun. This is kind of a little bit of history, a little bit of update. There's going to be a small bit where I'm going to talk about vaping a little, just because that's one of my of latest soapboxes I like to stand on. Obviously, like I said, this is a lecture used on other things. So don't some of the slides I'm just going to breeze through. Our objectives, we're going to talk about some of the differences between patterns of cardiac disease between men and women, some of the shortcomings in our current system that exist for women's wellness. We're going to look at some disease processes that that are a little bit more important in female populations. And like I said, I'm going to, somewhere in here, throw in some vaping stuff. This is a lecture that I've often given to residents and trainees. We often use patient examples. So I'll go over these quickly. We're going to loop back around to this at the end. But 3 patients, these are all based on patients I've actually had. So one, we have a 67-year-old female who came in with a day's history of dyspnea and new renal insufficiency. She's known to have a stroke previously, high blood pressure, cholesterol. She's on a few medicines, aspirin, cholesterol medicine, some blood pressure medicines. And she's also known to have diabetes, no echo. So there's nothing known about her heart. So that's how she showed up. A slightly older lady, 73-year-old female with a lot of medical problems, asthma, high blood pressure, cholesterol. 17 years prior to her presentation, she had a coronary angiography that showed what she reports as calcium, but as far as she knows, doesn't have any heart disease specifically. She takes an aspirin, a cholesterol medicine, and she takes nitroglycerin every so often, but she just says, you know, that's just for chest pain. And it turns out it's when she was calling her primary care provider saying she needed a refill from on the nitroglycerin, it came out that she was using it a lot. They sent her to the ER, and she was found to have a heart attack in the ER labs. And our third patient, a little bit younger, 56, diabetes, cholesterol, kind of poor medical compliance and unknown history, unknown cardiac workup somewhere at a different hospital. She also presented with shortness of breath. She was also in atrial fibrillation with a fast heart rate that spontaneously corrected. And from the ER, she had a chemical stress test done, which showed some regional abnormalities. So 3 different pictures, all women with some kind of heart disease. So quickly, just some historical points. This is some account of disorder of the breast. So very old, this from 1768. one of the original texts having to do with heart diseases. As you can see, it's a little bit archaic these days, but a quote I want to share from this: I've seen nearly 100 people under this disorder, speaking of angina pectoris, of which the number, there have been 3 women, all the rest were men, near or past the 50th year of age. I highlight this because just very early on, the idea of heart disease being a man's disease had been established. So, this is kind of change our thinking. Now, this is an old picture. This guy is René Laennec. He's a French physician. And I bring him up just as a sort of a little background story of how, to me, from the beginning, women and heart disease have been very important. He lived the late 1700s, early 1800s. I think he died 1826. And so back in the day, the way that heart exams were done was by having a physician put his ear directly to the chest of his patient. Dr. Laennec here had an older patient who wanted to bring in her daughter for evaluation of palpitations, I believe. And because she was this nice, young, beautiful woman, for reasons of modesty, instead of putting his head right to her chest, he took some paper, rolled it up into a tight tube, placed that against her chest, so to maintain some distance when doing the cardiac exam, and actually found the sounds to be amplified. And so the earliest stethoscopes, so this was what was really inspiration from some of the earliest stethoscopes. The earliest stethoscopes were just these hard linear structures, but I think it's really important and very telling that it was a woman who was brought about the inspiration for this to be involved. So I think women have a place in heart history from the beginning. So we're going to jump ahead a couple centuries. So American Heart Association in 1960s actually hosted a conference aimed at women about cardiovascular disease. And the title of that conference was, "How can I help my husband cope with heart disease?" So even though women were involved in the conversation, it was in purely a supportive and caregiving role. Around the same time, they also published a pamphlet about diet, a good heart healthy diet, and that was titled "A Way to a Man's Heart." So early on, heart disease was owned by men, and women played a supportive role. So I like to think of in the history of heart disease in women, there's kind of been a few different waves of awareness and action. So in the very first wave is just the acknowledgement that women get heart disease, since early on it was just thought to be a disease of older men. This might be fuzzy in case you can't read this, it's just a little graphic. We have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition, but medical research using women as subjects just never occurred to anybody. And sadly, it's funny because it's true. When we think of some of the landmark studies when it comes to cardiology, there's the Veterans Affairs Cooperative Study in 1974, same year that I now know ARC was founded. Multiple risk factors here in Hawaii, multiple risk factor interventional trial in 1976. Physicians' heart study a little bit later in 1989. But again, these were all studies that looked at men, typically men age 55 to 75, somewhere in there, and predominantly Caucasian men too, which even narrows the range of what's being looked at. So if we were in a room, I'd ask you guys who's heard of Yentl. I'm guessing many of you have. When I give this lecture to the residents, they give me a blank stare. So, but as you know, Yentl is a movie where Barbara Streisand played this character who wanted to study the Talmud. But in order to do that, she had to be a man. So she cut her hair and dressed and did everything to act like a man. And this this article in the New England Journal of Medicine back in '91 highlights what was called the Yentl syndrome. And basically, this acknowledged this male normalization of what heart disease was. And for women to have heart disease, they had to very much fit into the patterns of what was known as a typical angina. And anything outside of that was already called atypical angina. There's inherent bias in that language, of course. So so in this first ways, the changes acknowledging that women had heart disease at all, but we had a very skewed and limited perception of what that actually meant. And women still continue to have other issues as their priorities. And, you know, heart disease was put on the back burner. So about 20 years later, and I'm sure there's some things that happened, but some of the bigger events that occurred here in circulation, we have finally some looking at women. The female heart is vulnerable to cardiovascular disease, and looking at evidence and how to start doing prevention in women. And here, this American Heart Association had this guidelines for preventative cardiovascular care in women. And again, about 20 years later after the Yentl. And this is actually one lecture, the one slide's a little out of order, but the problem, one of the biggest problems when it comes to women is this perception that heart disease is an issue, that breast cancer is their #1 killer. Very often when women have cardiac syndromes, they're chalked up to something else, anxiety, stress, not the heart at all. The idea that they could be too young, and very often women, when they present with heart disease, they do present younger. And this goes for everyone. When heart disease doesn't occur in the family, they just don't think they could have it either. So again, to this end, there's the Women's Heart Disease Awareness Study. This just kind of took a look to say, all right, do women know they're getting heart disease? What are women thinking about? And this little graphic, basically from 97 to 2012, separated by ethnicity, which of course doesn't quite reflect the demographics of Hawaii, but you'll get the overall idea. Over the years, between Caucasian, Afro-American, and Hispanic patients, the understanding that heart disease is the leading cause of death in women, you can see, got a little bit better over the years, but still almost a third of women of color did not, were only a third were acknowledging or knowledgeable that heart disease was the problem. And this is just a graphic showing the same thing. So more than heart disease, lung cancer, or breast cancer, heart disease is the #1 killer. A lot of words on this slide, and this is a little more just for documentation, but to highlight a couple of the things here. Coronary disease, again, is the #1 killer of women in the United States each year. And heart disease deaths for women can amount up to twice as many deaths as all other cancers put together. And when we look at people dying from heart disease, more than half of those deaths are women. So, you know, not only we're getting heart disease, we're dying from heart disease. Many people, this goes for men and women, honestly, is that their first symptom is when they have their major coronary event. And sorry for the acronym, heart failure with preserved ejection fraction. The main risk factors for this: hypertension, age, and female sex. So heart failure is one of the most common, if not the most common, diagnosis upon hospital admission. So this is a very large population. So in the next wave of awareness is just this understanding of some more of the differences between men and women, both quantitatively and qualitatively. So when we talk about heart attack presentation, the classic typical angina, you think of the pressure on the chest, radiating to the arms, sometimes shortness of breath. And women obviously can have that, but very often in women, it might present as just some vague nausea, extreme fatigue, just an overall weakness, dizziness, coughing, which can also be a sign of new onset heart failure, palpitations, back pain. So there's very often a larger myriad of symptoms you can find in women. Interestingly, that's just anecdotally, my experience is you find all these in men too. And I don't know if it's that women tend to be a little more articulate than men, and men kind of like in caveman style, me hurt here. Women will expand a little bit more as to what's going on, but that's unfortunately put them into what's called an atypical pile. I don't know. That's just my thought. Going on with some of the heart attack symptoms. Symptoms can occur suddenly, but sometimes take days or weeks that they develop. What we see, and this is going to come back in a couple more slides, more often women will ignore their symptoms, or they'll just have a reticence to seek prompt medical care. And in this not seeking for care right away, this can lead to even further damage and potentially death. So this is all sounding pretty terrible. Is there any good news in all this? Not much. Women are like I said, they're actually often older at their initial presentation, but again, this is because they're not caught early on. They're more likely to die in their first year after having their first heart attack. They're more likely to have a second heart attack. And this, a little of this is because of delay of care. Some of this is because of skewed treatments. They're often sicker when they have that heart attack. Like I said, they're more likely to have ignored the symptoms, and they're going to often present later in that course because they will have had those symptoms for a longer time. And this is what leads to worse complications. So a couple follow-up studies. So the WISE study looked at, this is a study looking at symptom recognition among women, trends in diagnostic testing, and so looked at some of the effects of reproductive hormonal status. This was, so in this study, it found 65 women with ischemia presented with atypical symptoms. And specifically, they looked at the women who went on to have cath, and because of their heart disease symptoms, and then they compared some of these findings of angiography with cardiac MRI. And some of the findings out of this study, interestingly, so of the women sent for cath, 1 of 5 of them did eventually die of a cardiac cause. So this is real disease that these women are having. The real tough thing, and we'll come to this a little in the next study, that the majority of these women had modifiable risk factors. So when it comes to heart disease, we think of the modifiable risk factors: smoking, hypertension, hyperlipidemia, lifestyle changes, weight. These are all things that we can modify and change. And these women had it, but they weren't being diagnosed early on. And so the disease was progressing in them. Interestingly, 1 in 3 of the women who died actually had what we call non-obstructive coronary disease, which classically is thought of as not something significant, but as I'll talk about a little later, this is real disease, and we need to learn more about how best to treat it. And we have some approaches towards that. And it just highlighted the need for more studies and more looking into this. Now, Virgo was an observational registry, so role of gender on outcomes in young acute MI patients. This looked at a younger cohort of women with heart attacks, and they age matched them with men. And this was very interesting. What they did is a chart review, and they looked at the different coding, and the charting was explored. Amongst the, so again, these are age matched between men and women. There was actually less clinical diagnosis of high cholesterol by, again, using the coding charts. And in women, there was more overweight diagnoses, even for what was a lower BMI. So you take a male patient, female patient, women at a lower body mass index were more likely to have had the diagnosis of obesity and just given, weight loss advice, whereas men at even higher weights were not labeled as obese and were actually worked up for hyperlipidemia and often treated, therefore it was found and it was treated. And so this is, and it's a really, really interesting article. And it's actually, I'm pretty sure it's public domain right now. So if you were just to Google Virgo trial and to read the whole thing, it's really pretty interesting. And this is just their box. Again, I just have it more in the slides, but the highlights of this was just finding the objectification of women and healthcare professionals. And I'd like to say this was all on the part of male doctors, but there are female doctors in that mix too. They're more, like I said, they're more likely to be advised on weight loss and not given the full evaluation for validated risk factors like hyperlipidemia. And so clearly, if you don't check for it, your patient's never going to have it. And what they, further found in some post-evaluation is that these women, the fact that they'd go to the doctor, something is wrong, they're just told to lose weight. This creates a situation that it's actually less likely for them to seek out medical care. So even further exacerbating this delay to treatment that you get for women as opposed to men. And obviously, if they don't show up, you can't diagnose them. So, all right, hope you guys aren't falling asleep. This little girl in the front row of church falling asleep, and I hope that's not you. So we're going to take a great big deep breath in and out. And we're going to talk about vaping, just to switch gears for a quick second. I first put this into the lecture about a year ago, just because some of the studies on vaping were starting to come back. And our youth, our young people and young women especially are flocking to this because of marketing. Luckily, in the last year, there's been some changes in the laws, what's allowed, but we found that pregnant women are more likely to be vaping, and nicotine by itself is harmful to the developing brains of both fetus and kids and teenagers. And the worst thing with the vape is some of them actually deliver even more nicotine than a cigarette would, which can worsen the addiction. So the American Heart Association did present some recent studies showing that when looking at the endothelial cells, so the cells, lining the arteries, on cells exposed to serum of e-cigarette users, there's less nitric oxide and less of the enzyme that produces the nitric oxide compared to non-smokers. So the nitric oxide, that's what we need to keep those vessels nice and relaxed and open and not spasming. And even worse, the chemicals, so never mind the nicotine, the actual chemicals and the flavorings have been associated with cell damage and vessel inflammation. And I put this in the lecture again because there's an appeal of this for young people and appeal of this to young women. And, in no unquestionable terms, this is a terrible, terrible idea. They found that for vaping, it increases your odds of having heart attack, stroke, so all the things that smoking does to you. And, comparing e-cigarette users to non-smokers, still higher risk of stroke, higher risk of heart attack, higher risk of coronary disease. And so far it's looking like, even worse than that of cigarette smoking. Now, obviously we don't have 20-year data with vaping like we do, or 20, 40, 60-year data with cigarettes, but I have the suspicion that time is going to show that this trend will continue and worsen. So the American Heart Association definitely supports maintaining, maintaining regulation over use of e-cigarettes. And this is not meant to be a path to quitting smoking. And that's it. Back to the talk, back to the main talk. So in this next section, I'm just going to talk a little bit more about some issues that are particular to women. Obviously, some of these do affect men and women. Pregnancy obviously is a 100% female issue. So the nice thing is a healthy pregnancy is a great stress test. If you, and not only at the time, if it's a great sign that someone's cardiovascularly fit, if you've had a patient has had healthy, uncomplicated pregnancies, they're actually at a lower risk for developing heart disease later in life. But obviously time does a lot of things. What pregnancy is doing at the time, you have this increase in cardiac output. So it is truly like a low level stress test. One of the unfortunate things what we find in pregnancy is an increased risk for coronary artery dissection during pregnancy and in the immediate postpartum period. And I am going to talk about dissection in a few slides more specifically. Unfortunately, as maternal age risk, the risk of as maternal age increases, the risk for developing acute coronary syndrome with all these stress testing going on increases too. And there's also an increased risk for pulmonary embolism in women. I don't know if you guys heard in the news a little while ago, Venus Williams actually developed a pulmonary embolus very shortly after having a child, and her treatment was actually delayed. She was given all these other diagnoses, which you could bring in the argument of women of color and access to care, but that's probably a different lecture. But it's just, again, when women's symptoms aren't taken seriously, major disease happens like pulmonary embolism, and it can be missed. So hypertension in pregnancy, definitely an issue. We see plenty of folks referred for that. You can see it in up to 20% of women, of pregnant women. And usually we try to keep them somewhere below 140/90. Gestational hypertension and preeclampsia are big problems, and they each increase the risk for heart disease. For these, the biggest thing we have is just aggressive risk factor screening. There aren't any specific genetic tests, and we don't typically do serial echoes or anything or prophylactic aspirin in these cases. But the key is just to stay on top of it and treat it quickly and not just sort of wait and watch. Peripartum cardiomyopathy is a particular syndrome that happens usually in the last third of pregnancy, last trimester of pregnancy, or following up to 3 months post-pregnancy. And it's basically a spontaneous weakness of the heart tissue that happens with pregnancy. The risks include increased maternal age, having had many children, having many children in the same gestation, African descent, history of hypertension, preeclampsia, and cocaine use. Therapies include sort of some of your just typical blood pressure and heart failure medicines, including beta blockers. ACE inhibitors, that class of medicines, not safe in pregnancy. It is safe in lactation. So once postpartum, once everything's hemodynamically stabilized, women can start ACE inhibitors for that. And it's important to treat this aggressively. Refer for advanced heart failure therapies early in the course. You know, in some of these cases, anticoagulation is appropriate. In general, even without treatment, about a third of these women will get better with treatment that improves. But historically, I saw it, a third get better, a third kind of stay the same, and a third really do worsen to fulminant heart failure. I think with modern treatments, those numbers are a little bit better, and research is still ongoing on this. Valve disease in pregnancy is also something I like to highlight, especially here in Hawaii, where we have so many young women with a history of rheumatic valve disease. Luckily, regurgitant or leaky lesions are typically tolerated better during pregnancy. It's the tight lesions or stenotic lesions that are a little bit harder to manage. Mitral stenosis, which is super common with rheumatic disease, usually we manage that with balancing water status and heart rate control in the first tier. On occasion, we will do a valvuloplasty, so that's when we go in a balloon, open up the valve during pregnancy. It's not ideal, but it's actually safe to do in pregnancy. But there are limitations on what patients are eligible for that treatment. Aortic stenosis is a little bit tougher to treat too, and we really do try and address this before pregnancy comes. There are types of valve replacements. So Ross is a procedure where you take the patient's actual pulmonic valve, put it in the aortic position. The problem is with replacing valves for in pregnancy, mechanical valves have a really high thrombotic rate in pregnancy. So we try to, if we have to replace a valve, use a tissue valve. Try to keep the patient with their native valves as long as possible. That's it for pregnancy specifically. So like I said, I was going to talk a little bit about spontaneous a coronary artery dissection. And this is a picture just to kind of give a graphic of what's going on here. So here down the middle, that dark hole more towards the right of your screen, that's what we call the true lumen. And what happens in coronary artery dissection is the endothelium, or this inner lining you see here of the coronary artery, that spontaneously peels away from the next layer. And what you get is blood flow, these red arrows, blood flow going through the wrong lumen. It's what we actually call the false lumen. This, not surprisingly, causes pain, discomfort, and can compromise the blood flow. So, like I said, this is found, a little more common in pregnant women or postpartum women, but in general is actually more common in women. So 80% of the cases of spontaneous coronary artery dissection are found in women. And of those women, up to 20 of them are in the peripartum period. The average age is 42 years old. They typically do not have atherosclerosis, and they typically really aren't high risk for heart disease in general. It's actually found that up to 4% of acute coronary syndrome across the board can be acute dissection. And this is important because the way we treat it is different than the way we treat your classic kind of heart attack. Risk factors, like I said, the peripartum period, fibromuscular dysplasia, which I will also talk about in a few more slides. Extreme emotional distress, exercises, known connective tissue disease, familial history. And interestingly, the treatment is conservative. So our typical going in with stents and balloons and opening up and leaving stents behind. that gives a worse outcome than just treating conservatively. So basically keeping blood pressure in a good range, keeping heart rate in a good range. If there's high cholesterol, obviously we treat this. We use nitrates and calcium channel blockers to help just relax the blood flow and keep pain down. But just medical treatment is the recommended. And this is just an image of a CT after a patient who had a spontaneous dissection. This is aorta. This is the artery branching off of the coronary artery coming off the aorta. And you can see in this middle area where the nice yellow arrows show you, it's shady. And that's, you can sort of imagine where some of the blood is not going the way it is, down the path it's supposed to. But as you can see, distal to that lesion, there is still blood flow. So this person was treated conservatively, and 10 days later, and obviously this image is a little different image level, the dissection was completely resolved. So that flap just kind of goes back, it heals back in place. And for all intents and purposes, things go back to normal. Obviously, if there's disruption to the blood flow or really serious symptoms, you have to act. And sometimes these people do have to get stented. But when it's possible, conservative treatment is better. So, deep breath. Another disease process that is found more commonly in women is microvascular disease. So what I'm talking about when I say microvascular disease, so here's the heart, here are our arteries. And in this first section, when we classically think of coronary artery disease, here's your nice open artery, which is what we hope we all have. Here's where we start to have some plaque buildup, which in reality is what most of us probably have. But what you really don't want is things to progress here where you've got this hardened artery, this really small puka where the blood's flowing through. It's not hard to imagine how this kind of vessel would create chest pain syndromes. Microvascular disease, what you have is in general, the vessels are a little bit smaller, but you get hypertrophy and constriction of the walls of that vessel. So you can see de facto that lumen is just as small and dysfunctional as a atherosclerotic lumen, but it's a completely different disease process and a somewhat different treatment approach. So just to kind of highlight microvascular versus macrovascular, in the microvascular disease, you often have some diffuse discomfort, fatigues, shortness of breath, but nothing, real specific you can point to. You have these constricted vessels on angiography, but you won't find distinct blockages. Functional vascular imaging is still often abnormal, however, and the treatment is, this is where what we call conservative, but I don't think that's really the right term for it, but blood pressure medicines, treat high cholesterol if there's any. There's a question of whether or not there's an inflammatory component that's still up for question. Whereas in your macrovascular disease, so the disease with those atherosclerotic plaques, you're more likely to get that crushing chest pain, radiating, those more classic heart disease, heart attack symptoms. You often will have an isolated culprit plaque or specific, distinct plaques you can see. Stress test and angiography often do match up. So the area of the stress test that's abnormal, when you go to cath, you find blockages in those areas. And the treatment for that is often angioplasty, stenting, bypass surgery, and the same medicines. The good news for microvascular disease is that it responds really well to what we call guideline-directed medical therapy. So when you maximize these patients' use of beta blockers, ACE inhibitors, usually you have an aspirin just to help with blood flow and everything. This hypertrophy and constriction does relax. So, almost all these patients do get statin and aspirin unless there's a reason not to. And then the beta blockers, calcium channel blockers, and nitrites. And additionally, with these patients, cardiac rehab or prescribed exercise works amazingly well. So what happens with that is the heart and the vessels just get more efficient at distributing the blood, at utilizing the oxygen in the blood. So prescribed exercise works really well in these patients too. Lifestyle modifications, of course, if they smoke, they have to stop smoking. Et cetera, et cetera. And yeah, that's just a slide showing it's women. Another disease process that we find more often in women is rheumatoid disease. Again, plenty of men with rheumatoid disease, but it's just, it weighs a little, quite a bit more heavily on women. So in the setting of rheumatoid disease, and For most of this, it's based on rheumatoid arthritis, but it's kind of extrapolated for lupus patients and some of the other autoimmune diseases. 50% of these rheumatoid disease patients will have premature deaths due to cardiovascular disease. So it's very common in this population. The effect of having rheumatoid arthritis or rheumatoid disease is comparable to being of diabetes, which is one of the biggest risk factors for developing cardiovascular disease. These patients get the double whammy of being in a chronic inflammatory state, which is believed to have a lot of impact on the progression of atherosclerotic disease. Plus they're sedentary, so they're not exercising, and those lifestyle modifications of being more active are truly more difficult in this population. All the traditional risk calculators we use underestimate the impact of rheumatoid arthritis. So it is a section of patients we're often missing when we're kind of going through our normal risk stratification. The use of non-steroidal anti-inflammatory drugs is controversial. A lot of these people, in order to be functional, in order to move, have to have them, and their role in cardiovascular disease is still up for question. And we do know for sure that steroid use is associated with increased cardiac disease. And again, many of these patients, in order to be functional and have a functional life, are steroid dependent at periods, if not nearly permanently. And we know that one of the most standard treatments for rheumatoid arthritis can exacerbate heart failure. So these patients are very often in a real rock and a hard place. So the manifestations we see, like I said, you get an increase in atherosclerotic disease. You actually can have specific valvular heart disease manifest, and that those can increase your likelihoods of developing arrhythmias. You also see increased rates of irritation of the lining around the heart and within the heart, so pericarditis, endocarditis. There's an increased risk of heart failure for these patients. You've got increase in myocarditis, which is inflammation of the heart muscle itself, and the microvascular disease, like we just talked about. All of these are SED rate, et cetera. These are different lab tests that are associated within some increased plaque formation and heart events, and specifically rheumatoid factor and anti-nuclear antibody independently, regardless of how active someone's disease is, are associated with an increased risk for heart attack and heart failure and vascular disease. So all of your rheumatoid patients are at increased risk. As promised, fibromuscular dysplasia, again, happens in men, happens more likely in women. So very often when we have patients who have really uncontrollable hypertension, fibromuscular dysplasia is kind of incidentally found and can be the factor in it. What's involved is an abnormal development or growth of cells of the walls of the artery. So before, like that picture of the artery where you saw that wall peeling off, that wall becomes abnormally thick. It's particularly in the renal arteries. And this is somewhat familial, more common in premenopausal women and women under 50. Treatment is typically, even still, very aggressive antihypertensive therapy. Very often these people need 3 or 4 medicines to have their blood pressures controlled. And even then it's often borderline. And when there's failure of medical treatment, there are surgical and interventional options that you can look into. Typically they don't tolerate stenting well, but some anatomy is amenable to it. This is still being researcched. Those are the big kind of topics I wanted to talk about, but when it comes to differences between women and men in heart disease, there's new research coming out on electrophysiological differences, the impact of different conduction abnormalities in women versus men, better understanding the hormonal effects on lipids. We all know the sort of kind of protective effects of menstruating, but that is not conveyed by hormone replacement therapy. So there's huge bodies of work looking at the effects of hormones on lipids. There's a lot of psychosocial differences. Women are more likely to live below the poverty line. And we know how poverty, access to healthcare affects outcomes. And that hits women a little bit more hard than men. Impact of depression, stress, and abuse. We know that uncontrolled depression makes heart failure worse, and heart failure makes depression worse. Uncontrolled heart failure makes depression worse. So these things are intermingled, and again, very often diseases that are less treated or worse in women. Differences, and there's just, again, with these treatment biases, differences in valve surgery referral. Women are less likely to be referred to for surgery. Hopefully with the advent of more percutaneous and just a little bit more active role in women's voices in medicine, this will be changing. And just basic differences in metabolism, which is a whole world I know very little bit about. So as I've hit all these things like this little kid, I hope you guys are really worked up and excited, even if you're not exactly sure what you're most excited for. Hopefully something struck a chord with you. This is a slide I stole from the American Heart Association, just with some differences between men and women. And again, this is more for the lecture, just so it's if anyone wants to go back and look and really read, and any number of these could be a new lecture base. So before I finish, to loop back to our patients, our first lady, our 64-year-old lady who was admitted with 1 day of shortness of breath. Key points in her history: she had stroke 6 years ago, which we know is a vascular disease. She had some inconsistent history, weren't totally sure what was going on. She turned out to have heart failure with preserved ejection fraction and 3-vessel disease, and she was referred for coronary artery bypass surgery. So real disease, and probably had it for some time in this inconsistent history. Our next lady, our 73-year-old lady with all the medical problems, and who had 2 days of chest discomfort and was found to have some kind of heart attack after using the nitro. She had classic heart disease, and very often we call the left anterior descending a blockage in that artery the quote unquote widowmaker, which, let's talk about more gender bias, but she had major and classic heart disease that she had kind of been self-treating and had been told was anxiety for many years. Our final patient, our 56-year-old gal with the poor medical compliance, some kind of workup at another hospital, and an abnormal Lexi scan here, turned out to have the microvascular disease. And this lady, who I do remember, had this workup, had a cath that didn't show any blockage, and she walked away from this saying, "My heart's normal, my heart's fine," and when in fact she had these very small disease vessels. And this poor medical compliance had, the physician and social work and everyone around kind of worked a little harder to make sure she could keep access to her medications and understand the importance of it. Some of this discomfort and could have been prevented. So she's doing much better now. So I hope this was fun. I hope this was interesting. This is a topic I love to talk about so much, just because I have a lot of female friends. This is actually a lot of members of our heart department at Queens. I have a great support groups like this. I obviously didn't know you guys when I was coming up, but it's because of groups like you that opportunities for me have been made. So I thank you guys for the work you do and the outreach you do, because it makes a difference and it brings people up. This is the other reason I do this. This is me with several of my nieces, not all of them. And at least one of them does want to be a doctor when she grows up. But it's just, we do this to just help to keep others well and help with the next generation.
On video, so we can go back and revisit some of that. Some of the questions that came up, since symptoms can be so sort of vague and general, things like nausea and back pain and tiredness, how do you know when you should seek medical attention?
Absolutely. For me, one of the biggest advices, one of the biggest helpful things is how active a person is. And so, you know, besides just feeling great and exercising because, you know, you get all those good endorphins, it's a great way of tracking how you're doing. If you're able to walk 3 miles briskly every day and every so often you get this nausea, it's got nothing to do with your walk, then that's probably got nothing to do with your heart. Now, if you find that that 3 mile walk is now a difficulty, and at, you know, a mile in, you're slowing down and you're feeling awful and something's going on, you know, heart symptoms are still very often activity linked. So the first thing is I encourage everyone to stay as healthy or stay as active as you can, because that's going to give you it's sort of a checks and balance that, you know, if I can do all these things, there's no way a weak heart's going to be able to keep up with these things. Now, some of us, you know, because of other diseases, because of other situations, might not be able to do that. So you look at other things. No, if you know your cholesterol has been great, if you've kept your blood pressure, you know, if you've seen a doctor regularly, you know your blood pressure is low. You know your weight's in a good range. It's all these things, you know, it just helps you make the decision. Is this something I need to worry about? But, you know, this is where your docs come in, and having a sit down with your primary care doctor, and sometimes having someone else just objectively listen to your symptoms. You get that aha, you're like, wait a second, every time it's chilly night, you get this weird, you know, indigestion, nausea. I think it's chilly night. Whereas in other places, you know, Eli, I saw you a year ago, you were walking 5 miles a day, and now you're telling me you're not doing this because you're just so tired. That's the kind of history I for sure worry more about. But it's, you know, it takes getting that full history and looking at all the different factors to think about.
Should women get a stress test? And if so, at what age should they look at that?
I'm going to answer that question with, should people get a stress test? And no, there's not an indication of getting a stress test just for the heck of it, men or women or whatever. Stress test, you know, a plain treadmill stress test is about 65%, and Ralph probably knows the numbers better, but they're not great tests. They have a lot of false negatives. They have a lot of false positives. So we want to be doing them in people that we have some degree of suspicion of there being disease. Ralph, for years, was one of our main stress test runners. And so when we start just willy-nilly doing stress tests on people without a reason to do them, we're going to get a lot of false findings, and it's going to lead us down a lot of so there are not any kind of recommendations as for asymptomatic stress tests. Do doctors still send people for it? Yeah, they do. And sometimes there's a reason for it, and sometimes there's not, but there's actually not a specific age we recommend just doing a stress test.
Are there genetic tests that might signal potential cardiovascular disease?
I guess technically the answer is yes, but I don't think most of them are really well vetted. And again, you know, with all these things, it's more kind of the overall picture that you want to look at. You know, a lot of the genetic tests, I mean, I don't send for a lot of them. My heart failure colleagues do. So once you know there's a diagnosis, there's very often we'll want to look at first degree relatives for certain things. But to, again, just sort of blanket test an asymptomatic population for things, it's not going to be very useful. But definitely we do use genetic testing once we know there's certain disease processes to try and track and find that in families. But we don't usually just sort of do that de novo. There probably are tests out there, but I don't think they're hugely useful. Again, Ralph, if you know more, please.
Well, this is an area of very intense investigation right now, and there are panels of genetic changes that are being examined for whether, when you add them all up, you can say this person is likely to get heart disease and this person's likely to get colon cancer, and those are coming along. And because sequencing is becoming so easy these days, I would be very surprised if 10 years from now there weren't genetic tests for your risk for heart disease that were broadly applied. But right now, I agree with Margo, that's not really the case. The other risk factors, though, that we recognize right away that you all know about, like smoking and high blood pressure and high LDL levels, those are very easy to assess and pretty easy to treat too. So we've got our work pretty much cut out for us. Those are the things that make a big difference in treating heart disease in women or men.
You talked about the autoimmune factor. Are people with lupus more likely to, more at risk for cardiovascular disease?
Yes, we are. So that's one of the reasons I do have some interest. I actually have lupus myself. Diagnosed myself when I was in med school, too much to the chagrin of the rheumatologist office I walked into. But but the good news is hydroxychloroquine in a lot, and this is more in the rheumatologic data than ours, is associated. So there's an yes and no. There's an increased atherosclerosis seen in rheumatoid patients, including lupus patients. And hydroxychloroquine, or which has been in the news a whole lot this last year, hydroxychloroquine is actually associated with decreasing the rate of that atherosclerosis. Now, in lupus people, I don't think it's as strongly associated necessarily with getting heart attacks, but again, just like having a positive ANA, which most lupus patients do. Now, you know, the thing about lupus is compared to like rheumatoid arthritis, there are like 13 different major findings in lupus, and you have to have 4 of them to have a diagnosis of lupus. But it's such a mix and match. It's such a variable disease. So one person's lupus might be very different than another person's lupus. So it is something that you have to just work closely with your rheumatologist and your primary care doctor to stay on top of, because not all lupus patients are equal. But I think most of the consensus is for lupus patients to be on some degree of hydroxychloroquine, unfortunately. And because of just those known associations with the rheumatoid markers to have increased risk, they are treated. Even like back when I was a resident, my rheumatologist at the time put me on an ACE inhibitor, using his theory being, you know, just the way for diabetics, we do often, if they can tolerate, put them on an ACE inhibitor for the renal protective. He sort of had this idea that it was a similar thing. I developed a cough and I'm like, this is nuts. I don't have time for this. So, and I actually haven't met any more rheumatologists that felt that way. But I think in the years to come, there's going to be more connections soon.
You mentioned hydroxychloroquine, which there's been coverage of COVID as not just a pulmonary disease, but in fact, a cardiovascular or having severe cardiovascular effects. And I know it's very early to try and evaluate data, but just wondered if you speak to that and any sense in affecting men and women differently in terms of heart effects.
You know, I don't know an entirely difference in the men and women. You know, if anything, COVID has helped us with, it's being on top of treating people quickly, because we've seen over and over what happens when the symptoms start to get bad and we ignore it. The cardiac cascade seems like it's happening more because of some inflammatory and post-inflammatory sequelae. In hospital, what I see a lot is rhythm issues. I feel like most of the COVID consultations I see are because people have developed abnormal fast rhythms. For me, it's a little too early to know for sure, because it's in that same group of things you see in really sick patients. So I don't know. Ralph, have you looked at, I mean, I haven't looked at a lot just because I'm waiting for more. Oh, I'm talking to someone else. I'm waiting for more, you know, to be known. It's a moving target for sure. I don't know. Yeah. Ralph, do you know much about the COVID and the heart? I don't know a whole lot.
Well, there's a viral myocarditis, which is a fancy way of saying that the infection can affect the heart. There's also a very interesting problem in some children who get a inflammation of the coronary arteries along with the inflammation of the muscle that looks a lot like a disease that's pretty common in Hawaii, which is Kawasaki's disease, which occurs in little children who get a rash and coronary artery problems. And that it's not Kawasaki disease that people are getting with COVID, children, but it is probably got some similar characteristics of inflammation in the blood vessels around the heart, the coronaries. So there are special COVID-related cardiovascular problems, but the biggest cardiovascular problem with COVID is the overwhelming pneumonia and the way that affects the whole physiology of the person. And so the specific cardiac problems with COVID are interesting, but they're not the big public health issue that the pneumonia is. There is the receptor for COVID, the ACE receptor, angiotensin converting enzyme receptor, is present in the heart, and that's why we use those drugs to treat the heart, to treat heart disease. And so the virus has entree to the heart in a way that leads to these other problems, almost certainly.
We had a follow-up question on the vaping discussion, and that is whether products such as CBD or cannabis, vaping those as non-tobacco products, are a problem.
Vaping anything is a problem because, yeah. So the short answer is yes, and part of it is what it's suspended in, and personally, I think there's a lot of good benefits to CBD. So this isn't an anti, medical marijuana, but the act of vaping is just a bad way of getting something into your body.
I was wondering about our statistics here in Hawaii in terms of heart disease, how we compare with the rest of the nation.
We're similar, our population is different. So it's hard to, we don't have that many Afro-Americans, and we have all these Micronesians that have terrible disease and Filipinos that have, so I don't think there's really anything different. Our ethnic mix is a little bit different. And I would say, sorry, in many cases, I find a wider variety of medical knowledge sophistication among the patients here. I mean, I grew up outside of Baltimore, so when I was in practice there, people know a lot of cardiac stuff, and I think here you just have a wider. I've got folks like you who are very, very articulate and know what's going on, and then I have folks that don't understand why smoking 2 packs a day every day is a problem. So, yeah.
There are some very interesting differences. We have a wonderfully heterogeneous population here, and there are some interesting differences in the way heart disease affects and interacts with other common diseases here. Japanese people have a very high frequency, surprisingly, of diabetes as they get old, but they don't develop the frequency of heart disease that's usually associated with diabetes until much later than would be expected based on comparison to other populations. And Native Hawaiians are just the opposite. They have a high frequency of diabetes also, but they tend to develop cardiovascular complications associated with that much earlier than other populations do. So there are interesting genetic background effects that affect our population here. And Hawaii is is a laboratory of population genetics in some ways. We haven't really exploited it for that, but it does affect the way the patients that we see and when they develop their problems.
Right, and of course we've got rheumatoid heart disease is the Polynesian populations are genetically predisposed to developing rheumatoid heart disease. So that's part of why we see so much more valvular disease here than other states, because we do have that population. And there are, talking about genetic metabolizing, you know, one of the main blood thinners that for years was used post heart attack, Plavix, is now known not to work well in Asian populations, to the point that there's actually, I don't know a whole lot about this, but there's actually this, there's a class action suit against Sanofi, the company that makes Plavix, because it seems like there was some knowledge of the drug not working well in Asian populations. And it's been dismissed in every state but Hawaii. So it's still, I guess, under evaluation, because it has had more of a effect here. Now, if the suit goes through, that's going to have other ramifications. So yeah, there's that too. So we try not to use that medication in those of particularly Japanese heritage.
There have been the studies that suggest that medical personnel may discount like reports of pain in African American populations compared to Caucasian. Do you see the same thing in response to women? It's like, oh, they're just complaining. It's not really that bad. Is it?
Sure. And, one of the tough things is, menopause can cause palpitations, can cause a lot of heart area symptoms. So I still do a full workup on all patients that come to me with cardiac S symptoms, but I can tell you it's less like it's very in certain populations, again, if I've got someone who's a vegetarian and exercises, never smoked a day in their life and doing all this great stuff, it is a little less likely that workup's going to come out with anything, but that likelihood isn't zero. So I'd say, like, I only know really how the folks at Queens operate, and I can say my immediate colleagues have very good and appropriate and aggressive approaches towards everyone. The tough for us, the tougher population is because methamphetamine is so common here. Those folks are a little harder to tease out because when you have folks who come in meth positive with classic cardiac symptoms and maybe even with heart, EKG changes, those folks are a little harder to parse out because in many ways, sometimes even doing some certain treatments and drugs are contraindicated. So those folks are a little bit tougher to approach, and unfortunately, that's both men and women. But but having said that, I have inherited patients who've maybe seen other docs who have just kind of written off as crazy lady chest pain or something. And then, with the workup, it does turn out. So it does still happen for sure.
Thank you again for your time, and Dr. Showett and Jabsum for organizing this event for us. Look forward to a future of healthier hearts.
Excellent. Thank you so much for having me. I appreciate it.
And thank you for the support of our graduate students.
Yes, that's what I wanted to say. Thank you to ARCS for all the support you've given our students over the years. It's really nice to be able to highlight women in medicine. That is something here at the med school. We are in the top 10 in the whole country for women in leadership roles at the med school. And I think Margo's experience and what she has to share just goes to show that as something to brag about from Hawaii, which we always want to have good news in these difficult times.
Cool.
Thank you, everyone.
All right. Thank you.
Thank you. Mahalo and aloha.
Aloha.
Yes, but I'll say this, the spine of